So I encourage you guys to sort of cheer them on. All right, and then this whole concept of culture. The other reason why we're doing this is we want to change the conversation. We want to, you know, it's about talking about overuse, but it's about why we end up in certain testing scenarios. It's about why we get to treat sometimes, and it's about changing the process and improving outcomes for our patients. And so we want to change that. And then it's the students. Okay? So these are you guys.
Yes.
I think medical education right now, everyone has been talking about how do we teach this concept of high-value care, something that we haven't been taught when we were in school. How do we teach it to you guys? And this topic keeps coming up, and you know, to be honest with you, medical students are, you know, Mount Sinai medical students are one of the smartest in the world, anywhere. It's not really a question about can we teach it to you, can you learn it? It's about how can you apply it? Can you make a difference in the settings around you to actually improve patient outcomes? And that's what we're going to find out, and that's what we're going to try to do this year. Okay? And it's about doing this together. So John and Irene have been joining us in our actual committee meetings with the faculty and administrators, and we're setting the agenda together. We're setting the priorities, we're setting the projects, and we're talking to each other about how to move this forward. And that's what we want to do. We want to work on this together. Okay? So I'm going to introduce a little bit of the format about how today is going to go. So each of the teams here, okay, there's 3 teams, each with faculty mentors. So either one person or members of the group are going to come up in front and they're going to give a 5 or 6 minute pitch. Gonna be time. It's okay to go over. Okay, but we will. Dennis Chen and Tom can jump on a table and start tap dancing if you go over. And then afterwards, the judges are going to send their barrage of commentary over to you guys. And if I could, after you guys present it, the team can sort of come up in front and sort of field the questions and comments together. That would be much appreciated. All right. And then at the end, what we're going to ask is the judges are going to vote via text onto on basically who gave the best presentation, best idea, the best pitch. Okay. And then we'll sort of have a tally at the end. And also at the end, if I can ask you guys, okay, with your cell phones, I know you all got them. To sort of text away and kind of vote for your favorite pitch, okay? Just to kind of balance this out. All right. So.
Wait, can I just jump in?
Yes.
So
please.
yeah, to do that, you basically just type this into any browser. You will then be asked for a session key, which is this right here. I'll open it up at the end for 2 minutes. It'll be open, kind of the way that it is on any like game show. And then after 2 minutes, we'll just see what the results are. So that should be fun. Okay.
Okay, so we'll do that. So I'm going to introduce the judges, but I kind of want them to introduce themselves, okay? But I think you know some of them and some of them you may not, all right? So we'll start with over here. The first one is Dr. James Dunn. Okay.
Thank you. Hello, good afternoon. I'm Andy Dunn. I'm the Chief of Division of Hospital Medicine. That means I run the hospitals here and for the health system. It's a whole bunch of 90 doctors, a whole bunch of NPs and PAs. So it's always great working with our students and residents on the wards. My area of research interest tends to be in anticoagulation thrombosis, like things like DVT, PE, and perioperative management of warfarin. But more lately, it's been in healthcare delivery and how we can deliver care more efficiently, transition and discharge patients more safely in a more timely manner. So a lot of my work recently has been with the group on focusing on those areas. My other role is with the ACP, the American College of Physicians. I strongly encourage anyone considering medicine to go and join the ACP. I was the governor of the New York chapter, and now I'm chairman of the board of the National ACP, which is a lot of fun. And that's an organization very much focused on value and providing high value care. So it's important to me, and I'm glad to be here.
Awesome. Next person is Dennis Chang.
So I'm Dennis Chang. I've been a hospitalist here about 7 years, and I also run the 3rd year medicine clerkship. So I don't quite have the other stuff that Andy does. So that's what I do.
Right. Deborah Kornstein.
Hi, I'm Debbie Kornstein. I actually do not work here, although I did for 16 years, but not as long as Andy, so that's good. I am mostly an educator and also a health services researcher, and I have an interest in overuse, and I've done research in the area of overuse. I'm currently working at Sloan Kettering, where my title is Director of Clinical Effectiveness. which if anyone knows what that means, please let me know, because no one I know knows what it means, which is the beauty of my job, actually. Where I was really hired to actually operationally try to reduce unnecessary care, which, believe me, at Sloan Kettering is a monumental task.
And next up is Dr. Yasmin.
Hey guys, I am, as a lot of you guys know, I'm the director of the East Harlem Health Outreach Partnership, which I run with you guys. And I'm also a clerkship director for the Interact Clerkship. And in my other life, I'm also a visiting doctor, so I make house calls in my day job. And I am really happy to be here. High value care is sort of like central to everything that I do at EHOP or at Visiting Doc. And what's really neat is getting to be next to two of my mentors. Yes, I am younger than Andy and Deb. They were my attendings back when I was an intern, but I am older than Dennis. I have no idea how old you are.
I'm extremely middle-aged. Thank you, Harry, for inviting me. Harry made it very clear that the only reason I was invited is because I have an English accent. So I'm a rheumatologist and vice chair for faculty affairs in the Department of Medicine. So that really means I'm involved in wellness, education, promotion, and discipline, not in that order. I'm primarily an outpatient physician, but we do, in rheumatology, we see lots of patients who are referred for abnormal or normal testing, blood testing. And a lot of the time I think to myself, why on earth was this test ever done? There's a lot of mismanagement and inappropriate testing, so happy to be invited. Thank you very much.
Thank you for coming.
All right, so without further ado, we're going to have our first student group present. I am their mentor, and I'm very proud of them. So we have Irene, John, and Rena, who are going to come up here and talk to us about their project on folate ordering. You guys need this? Okay. Is it on? Yeah.
Hi everyone, I'm Irene.
I'm John.
I'm Rita. So as you guys may all know, there are numerous medical resources and tests that are overused and can be decreased today. As a group, we wanted to come up with a creative way to decrease a commonly used test that is largely unnecessary in modern American healthcare. So we chose folate lab tests. You might be wondering, what is folate exactly? Well, it's a B vitamin. It's commonly found in a lot of kinds of different food like oranges, vegetables, bread, and even cereal. It's important in DNA production, and a lot of pregnant women take it to prevent neurotube defects. Now, in the early 1990s, about 6% of the population was folate deficient. Then, in 1996, a law changed. The U.S. implemented a mandatory folate fortification of enriched cereal grains. And ever since, the percentage of people who are folate deficient has decreased drastically to almost 0%. And in reality, even when a patient is folate deficient, their folate levels are easily replenished with just one hospital meal or even just a bowl of cereal. So given all this information, folate lab tests are still ordered very frequently. For example, at Beth Israel Deaconess, 2,093 folate lab tests were ordered in the inpatient and emergency department over a 12-month period, costing them $300,000. And of these 2,093 lab tests, only 2 patients had deficient folate levels. But even given all this data, no change in clinical management even occurred.
So how can we decrease folate test ordering within our own hospital and save some money for our patients? Here's what we propose. We will have 2 main interventions. The first is an educational intervention to raise awareness among our own staff. Instead of facilitating passive learning, such as by giving a lecture or sending an email, we're hoping to do something more dynamic. So what we'll do is that we're going to place some educational props in an area where our target population tends to convene, such as a nursing station or a break room. And it will consist of an educational poster, as well as small boxes of cereal surrounding it. So why are we having cereal? So we want to demonstrate the point that a single bowl of cereal can replete a patient's folate levels. And this message will be printed on the cereal box itself. Plus, we figured free food is always a good way to attract people over. On top of that, we're also going to have a raffle drawing to answer the following question. How many deficient folate cases did Mount Sinai Hospital encounter in 2015? We hope that by having a friendly competition and providing a prize incentive, we can get participants to actively engage in their own education and to promote critical thinking and conversation about this topic. To further emphasize the point, we will have a day 2 to this educational intervention. And what we'll do is that we're going to, along with the announcement of the prize winner for the raffle, we're also going to repeat and convey the same messages that were conveyed through the prompts that we put out on day 1. So we hope that by following up, we hope to repeat these ideas and reinforce these ideas among our staff. This intervention is relatively low effort because it only requires us to drop off and pick up the prompts. And we hope to be able to scale this intervention throughout our hospital.
So the second intervention we want to do is we want to do an electronic intervention, primarily using Epic. So currently, right now, if providers want to order fully in Epic, they have the option of ordering a combined test option, combining vitamin B12 and folate serum. And this is done because those two tests are usually ordered in conjunction with each other. And what we propose to do is remove this combined testing option. Now the reason for that is because in the Beth Israel Deaconess study that Irene talked about previously, they found that 85.2% of the time that folate serum was ordered, it was ordered in conjunction with vitamin B12. So we feel that if we remove this combined testing option, we will further reduce folate serum testing and then further break the culture of ordering the two tests together. And of course, we don't want to alarm anyone about the change in ethics, so we propose approximately 2 to 3 weeks before the actual test option is removed. When a provider orders the combined test option, a pop-up window appears informing them that this option will no longer be available at a specific date. And really just to kind of drive this point home, making it more relevant to Mount Sinai Hospital, we did a really quick chart review and found that in June 2015, 361 folate tests were ordered. And each folate test costs around $19 a pop. So we can figure that if you assume constant ordering over the entire year, that we can save the hospital over $80,000 a year if we reduce folate testing. And that's what we really hope to do. Thank you everyone for your time, and we will like any questions. Thank you.
Okay. Folic acid, how many?
361 tests
Just in 1 month. Yikes.
It's a lot.
Yikes. Okay. Judges, thoughts, comments?
So, given the fact that your display is going to include cereal, you're not worried that people are going to eat it and you'll have nothing left to educate out there?
That's what the raffle is for too. So that's an extra layer of incentive.
So great presentation, it was terrific. We have one question. I think you showed how important this is and relevant. One is, what's the difference between cost and charge? In other words, is $19 to you the charge of the test or the cost of the test? And how would the difference be important to the project?
So that is a really great question, and I think our team just discovered the difference of cost and charge yesterday.
That's in time.
Very different. So that is the cost of the test itself, whereas the charge is a little bit more complicated to figure out. And I'll be honest, I'm not gonna lie, I don't 100% know. The intricacies between the two. Yeah,
Does anyone know in the crowd?
Does anyone?
Well, it depends on your insurance company and all that. So
Yeah.
there's no one answer.
Yeah, but you said it's an awful lot more, maybe $100 or more. But use a relevant one between the cost.
It is. So in a retrospective study by Beth Israel Deaconess as well, they've said, this is a different study, that the cost of like 10 years of folate test was around $168,000, but the charge was like $10 million. And they didn't really give any reason as the difference of the two. They just said that's the number and that's it. So it's it's an interesting fact.
I have a comment. I agree. I think it was a really good presentation. You set the stage really well for it. I loved the fact that you're planning a multimodal intervention, because in the literature of like trying to do interventions to stop people from doing stuff, multimodal interventions seem to work well. And I love the fact that you're handing out cereal and doing a competition, like all that stuff is great. The one thing I would say is you should, whenever you do an intervention like this, you should be addressing the drivers. So, so it might be worth getting more information. It may be that education is not even a problem. Because when I look at this, the first option, when you go to order a B12, the first option is B12 and folate, and the fourth option is vitamin B12. So the chance that somebody, because even the next one is B12 binding cap, where you're like, well, I don't want that, I'm just gonna click B12 and folate. So it may be that just your EMR intervention is all it would take. If you put just vitamin B12 serum at the top, it may be that nobody would ever order folate again.
Yeah.
So,
Yeah, it's a really good point, because that's actually fairly universal as well. So many lab companies will actually bundle the two. So it's what you're, and I have no idea why they do that, but it's maybe to get more.
for megaloblastomia workup from like 1952.
Right, it's just
Completely relevant now.
Keep going.
No, I'm not.
So, no, I was gonna say the exact same thing. I think that, this was a fantastic presentation. It's funny, I was sort of waiting for you to sort of say, like, what is it? Why do we do what we do? And I think that there was sort of this general assumption that we do what we do because we don't know enough. And that's probably true. Yeah, probably we don't know enough about folate. But I think also it's just practice, and I think that one of the things that I love that you're doing this through Epic, because I think that that's really the way, just uncoupling it, and just as Deb said, maybe putting the B12 option as your first option, and maybe making folate, I don't know if they can code it in Epic in a certain way, like do not order unless, I don't know. But that's exactly the way to think about it. I wonder, did you guys think about doing a needs assessment before sort of approaching this? Because I think my concern is that there were a lot of assumptions.
Yeah, I was getting at this one.
Yeah, that there are a lot of assumptions about why we do what we do, and in fact, it may be something that's really just practice related, or just it's something that's sort of embedded in the EMR, and not really necessarily provider related. But I'm curious.
No, we haven't thought of doing a needs assessment, but before we came up with intervention, we actually did a chart review. And we're actually very excited about the Epic intervention because we did notice that in our chart review, a lot of folate tests that were ordered were usually coupled with vitamin B12. The thing about Epic is that it will take at least a few months for it to implement. So we're hoping that, or more, and we're hoping that in the meantime, we can also do the educational intervention. And so in that way, we can sort of measure our impact at various points within our intervention due to various types of intervention.
So I agree. I think you do want to do some sort of needs assessment, because if people are ordering this as a resident, so you do want to just get a sense of like why they're ordering, right? Because they may need no education at all, and all you have to do is prescribe, and like that's all they really want, So you might be able to actually even simplify it. The other thing that I would almost ask, and this is probably a bigger intervention, but why would we ever order a folate ever? Like, is that something we should just talk to the lab and be like, just don't ever run it? I mean, like, what is this, 2 out of 2,000? That's 0.1%. I mean, why do we even have a lab that even runs it?
It's very close to no value, right?
Right, exactly. So why not just get rid of it? Right?
Yusuf, I'm going to ask you a question since you're a rheumatologist, and I know you use methotrexate, something that we don't use. I know some patients are on folate. Is that a consideration?
So we use it primarily because some of our chemotherapy drugs for rheumatoid arthritis deplete folate, so we use it as a supplement. But we don't ever test folic acid. We just deplete it, so that's not really an issue. And when my patients get a bit time about checking their folate levels. The question I have is, in the Boston study, did they look at the prevalence of B12 deficiency as well? And one of the concerns is if you're going to stop people ordering folate levels, what will happen to B12 ordering levels? And could that be associated with morbidity and potential prolonged hospitalization and cost?
That's a good question. I don't exactly remember if they ordered, if they actually checked the B12 deficiency. I know in our really quick chart review, we actually looked at folate and B12 levels, and we found that neither of them were deficient. We did like a quick spot check of those 361 tests. We did like 10% that we actually looked into, and neither of the two were deficient. That's a good question though, if reducing folate testing actually reduces B12 testing. So I imagine B12 testing is more important and actually clinically relevant.
Certain groups like alcoholics and so on.
Yeah, you
Right.
want to track
Right.
that when you do your intervention and make sure that, like, as a
Not
potential
harming.
bad, yeah, as a potential
Right.
bad.
So I'm gonna cut in front because we're running out of time. Okay. Thank you, guys.
Yeah, I think it's loud enough.
All right, we're voting at the
Are we
end.
voting?
Voting at the
At
end.
the end.
Okay, so our next presenter here is presenting the project on proton pump inhibitors. This is Zachary Feldman. I was about to say it. So he's going to take it away, and Leah Fowl was the mentor for this group.
So yeah, thanks guys. My name is Zach Feldman. I'm a second year medical student working with the team here. Today I want to talk about another proposal to address many of the aims that we're trying to satisfy in healthcare improvement overall. So a lot of the ways we think about improving healthcare, whether it's the Department of Medicine or overall, are in three broad categories. So first, cost, right? So this is something that the folate lab intervention would directly address. Then there's the patient experience, which is how patients feel when they're in the hospital, how they interact with their doctors, how they feel about their care, and even hospital food, right? And then there's outcomes, so population health management, and how can we actually, this is what we think of when we think of medicine, the more intuitive one. So the project that I'm going to talk about today is the reduction of the overuse of proton pump inhibitors at Mount Sinai. And so that's a little bit of a mouthful, and for some of the first-year medical students in the room, a bit of background is that these are drugs that are used to control acid levels. That helps with gastroesophageal reflux disease, GERD, which you may have heard of. And it's often seen as sort of just kind of like a silent sort of add-on thing that people have. Doesn't really play into much of the inpatient management. But what I'll show here is that it actually can lead to some pretty bad outcomes on all three of those aims I talked about. So part of the reason that this may be overused so far is some things that we don't really think about all the time. So the patient, it's just another drug they take. They always get refills. Their doctor always orders the refills. And for the physician side, honestly, there's many other things people are considering when they're managing patients on the inpatient side. One of them may just be to, okay, let's renew this. But I'll show that the damage can actually be far greater than that. So what I'll demonstrate to you is that Mount Sinai is exposed to decreased outcomes and undesired costs due to Clostridium difficile infection. This has been linked to proton pump inhibitor usage. So a little bit of the background, just to give you a sense of scale here. So PPI use in the US has been increasing year over year for the past 10 to 15 years. In fact, from 2003 to 2009, it in fact doubled, at least among ambulatory care usage. And I'm sure those trends hold in the inpatient side as well. So some of the things I mentioned, the sort of let the ball keep rolling may be behind that, but there may be other drivers that we could address maybe in a needs assessment. So as we know, PPI use has been linked to poor outcomes. It's not just a silent drug. It may even be like a silent killer. C. diff is a massive problem in the US in inpatient settings, and unfortunately in Mount Sinai in particular. And PPI usage was associated with 7 times greater risk for C. diff infection in one study. Meanwhile, C. diff is an increasing problem, like I said. Overall, hospitals account for double the number of C. diff infections than are required in the community. So this is something that isn't just a trend that we need to address. This is a trend that we are causing. And PPI overuse may be a large determinant of our involvement in that. So where's Mount Sinai in this? So when I mentioned that study, we were talking about rates going from 3% to 6% or 5% to 9%. Mount Sinai inpatient, and that may be a little apples to orange because it was outpatient, but Mount Sinai inpatient has PPI rates over 40% in 2015. So think of how many patients are on these PPIs and they just don't need to be. And this is just the first cut of data that we did, but we can go deeper into the chart review and really see, okay, how many people would actually benefit from being taken off of these. So it's not just the rates that matter, right? So it's back to those 3 aims I talked about. So among the cost, that's pretty obvious, right? So if that 40% is much higher than it needs to be, that could be a great cost savings target. The Division of General Internal Medicine, wonderfully represented by our judges today, spent over $120,000 in 1 year just on IV pantoprazole, which is one of these medications. So imagine if you spool that up to other medications, other departments, you could really hit the cost. In terms of the outcomes, it's a little bit more alarming. So this is a schematic given out by the New York State Department of Health on C. diff infections. And what you want to see here is that Mount Sinai is a real prime offender in C. diff. So a lot of bad news on all 3 aims. So how can we address this? So like the group before, we want to have a multi-pronged approach. And this isn't something that would benefit from one approach. This should be a mandate. C. diff is fatal in some cases, and it leads to drastic reduction in quality of life. We should really attack this from multiple fronts. From the easy to implement and the things that we can scale up really fast, to maybe the more difficult, that take longer to address and may be a multi-month, multi-year project. But it includes things like education, to get people on board if that is necessary. It includes things like bringing it top of mind, because this is something that can really easily slip away from top of mind. So bringing it into the rounds and incorporating that into discussions that people are having from NPs and nurses to physicians and medical directors. We can incorporate decision aids to really just make it clear-cut who should be on PPIs, who should be renewed, and who shouldn't be. And then to some of the more structural changes that will really have sticking power. So from epic pop-ups that remind people, hey, this is linked to PPIs are linked to C. diff, to really requirements that there's a pop-up that will say this PPI will not be renewed unless you attest here that is necessary. And those type of things can hopefully address some of the really big problems that PPIs are leading to across all those 3 aims of healthcare.
If I could ask, where's the PPI group? If you guys could stand up with us. Okay. Here and there, I keep hearing that we have a C. diff outbreak in the forest. Okay.
Just to start, so that's a great presentation, really an interesting project. Can you be a bit more granular about the EPIC pop-up? Like what exactly, where were you in, how will you build this? Where will it pop up? At what stage of the inpatient state? Will you be looking just in the ICU to step down, or just all patients in general, or discharge?
So I think at least the preliminary data we have is just from the Department of Medicine, and I think with just in terms of feasibility, we would start there on the inpatient side. In terms of scale, obviously the bigger the better, but maybe we need to think of structural constraints. In terms of the modality of the pop-up, so aside from the renewal reminder, I think you're just talking about that second to last option. What I would envision is something that may be akin to the penicillin allergy that's sort of next to the patient's demographic information, a little red ticker or something like that. Or it's something that comes up when all the medications are reordered each time, even if it's not up for renewal. And it would be something where, and we could talk about different ideas, but something where you could incorporate education into it and just make sure that people remember that, hey, our rates are this. Maybe it would track live with C. diff rates at Sinai, something like that.
I think something else we envisioned with this kind of EPIC intervention is having, if you say, I'm going to renew my PPI, having kind of sort of decision aid come up when you click that and say, do you want to renew IV PPI, oral PPI, or an H2 blocker, or take them off entirely? So that gives the clinician a full spectrum of what they could do. Because if you're kind of ordering based on what you've done before, you'll just renew what you did. But when somebody gives you the option, you might rethink that decision.
It also makes it just as easy to renew a PPI as to do something else. So you're not just canceling out and saying, yes, I want it to get rid of the pop-up. It's just as easy to do something else instead.
You may want to also discuss this with a gastroenterologist as well. You don't want junior interns, with all due respect, to be stopping PPIs on people with GI bleeds, for instance.
Yeah, I mean, that led to what I was going to say, which is I mean, I think some of the evidence that you showed up front is very convincing that, PPI use is growing, which largely has to do with it being available, it's being available over the counter, in the outpatient setting, so it's very easy for people to get now. And that there are high rates of PPI use in the hospital, and I think there's an assumption that a lot of that use in the hospital is unnecessary, but to what extent is it unnecessary? Did you see things in the literature showing, what should the number be? It obviously shouldn't be 0, which is sort of the point that Yusuf's alluding to. There are some patients who need PPIs, they can be helpful. So we want to make sure we give it to those people and don't give it to the people who don't need it. So have you guys thought about that at all? And I think a lot of your messages are going to have to be targeted around that, like continuing necessary use and stopping unnecessary use. So have you sort of explored why is it being used unnecessarily, in whom is it used, and what proportion of patients who get it are getting it unnecessarily? Like any sense of that either from the literature or from, I guess,
So, go ahead. So in terms of the why it may be, so let's take the patients in whom, let's say, a priori they don't need it, right? So I think a lot of the overuse has been linked in the literature to automatic renewals and to staying on different formulations or to stay on certain dosing regimens. And those have been linked to worse C. diff outcomes as well. I think you hit a great point, which we didn't address at all, that we need to target this to make sure that we aren't reducing the necessary usage. And I think the decision aid modality of one of the interventions could actually be really helpful. So either it's automatic and it doesn't come up if a certain problem is listed on the problem list or a diagnosis is listed and that's active, or something that incorporates that into active decision making on the part of the provider.
I think the proof's going to be in the pudding. I think it's going to be very challenging to get down to that level of granularity.
Yeah, but I do.
But not impossible.
I agree. I think that the decision tree is actually going to be key here, and it's going to be, but sort of educating everybody on your decision tree is going to be sort of a cultural shift. I mean, honestly, this is really a culture shift. I remember like 6-7 years ago, I mean, PPIs were sort of an automatic. Your inpatient orders, when a patient gets admitted, a PPI is sort of a standard drug that you just order on everybody. So now this is really just being thoughtful about it. I think is really, really going to be tough culturally. And the only way to sort of break that is actually to not just educate, but also create decision trees. The problem is, and we found this at EHOP, is that we're also trying to reduce PPI use at EHOP. The problem is that people don't know where the decision tree is. So it's on our app, on our EHOP, but if you don't go to the EHOP, you're not going to know that the decision tree is there. So that's a little bit of a problem, like where you put that decision tree. So I think, although decision trees are really nice, unless there's something that's latent, maybe on every floor, or people are educated on using it, they're just not going to refer to it.
I think each of the intervention options kind of requires the other. And so
Yeah.
maybe you don't necessarily need some of the scale for some of them, but for instance, education really predisposes.
Yeah, and I would also, again, that, like, I know you guys did medicine, but we actually don't know who the biggest offender is. Is it medicine? Is it surgery? Like, so you might, because I think that overall this is like an awesome topic and the presentation, but what you're proposing is enormous, enormous scale. So
we
I
have
would
that
really,
available. That data is already available.
so I would really think about targeting either a floor or a unit or something and be very targeted about what the PPI use you're trying to stop, because there's a lot of different levels to PPIs. There's the discharge on the same PPI. There's the starting of PPIs, which might be simpler, just to prevent people from actually starting it. And then there's the continuation from the outpatient, which is also a much bigger issue, because sometimes nobody has any idea why they're on it in the first place, and that's why they're continued. So I think you have to be very targeted about where you're implementing and what PPI use you're trying to stop.
I'm going to cut you off right there, just in the sake of
But
time.
let me throw in one thing.
Okay, all right, go ahead.
So, great presentation, and I love the association between PPIs and C. diff. I think you made that really clear for everybody. It's a little different than saying if we stop the PPI, the C. diff rate is also going to go down. It's almost like a trial, which I think you'll have the opportunity to do. And I guess the question is, has that been done? There's probably been other efforts to decrease PPI use, and many of them showing the C. diff rates go down. Well, so
yeah, most of the
studies
that we saw just showed the association.
Yeah.
We haven't seen anything with an intervention.
So if you do cut out PPI, you should be able to see what happens to C. diff.
One thing that isn't necessarily a trial form, but it was broken down by levels of dosing and then none at all. And the association was scaled with that. That's, again, not in totality. But.
Okay.
All right.
Thank you guys.
All right. And last but not least is our team presenting on daily labs. We've got Gabe, we've got Adam, and we've got Iris, who will take it away from here.
All right.
Yeah.
So, we're going to be talking about the overutilization of daily labs and daily blood draws. What does that mean? So we're going to look at this from two perspectives for starters. And we're going to start with the patient perspective.
It's 4 a.m. and I'm tired, I'm in pain, and for the third time in the morning, they're waking me up to draw my blood again. And I don't know why. Why does this keep happening?
And now let's look at it from the intern's perspective 8 hours earlier.
Last patient of the day, just got to finalize some things up. I should probably order some blood tests, probably CBCs, BMPs. They're always ordered, my attending always orders them. It's better to have the data. Plus the phlebotomist is going to draw blood anyway, and I don't think they cost that much.
All right. So, you can see there's some problems, and there's some adverse effects that are caused by daily blood draws. We've touched on a few of them in the presentation. Number one, there's physical harm and discomfort to the patient. Number two, there is delirium caused to the patient by being woken up at a very early hour. Number three, there is a waste of time and resources to the nursing staff and the phlebotomist on unnecessary tests. And the fourth is that there's actual harm to the patient that come in other ways, for example, iatrogenic anemia. So there are a number of causes for overutilization of blood draws in hospitals. We are not going to go through all of them, but some that we've touched on include the following the supervisor's order in our classic hierarchical medical structure, the fear of missed clinical findings because we do have to play defensive medicine, and another one that we will touch on is that there are no real national guidelines for what constitutes an appropriate daily blood draw. So, we've got a solution. And our solution is multimodal, multi-pronged. On the one hand, we have a text solution involving EPIC, but the one we're going to discuss in greater depth is educational and building awareness. And we believe that such a solution has to come from not only the hospital side, not only the physician side, but also from the patient side. So, on the patient end, we might put up a flyer or a poster like this. And how might a patient react?
Can you avoid a blood draw today or tomorrow? Ask your doctor. I didn't even know I could do that. Doctor, do I need to get my blood drawn tomorrow?
Let me think about it.
And then our doctor, when thinking about it, can look at this chart, created and used in St. Paul's Hospital in Vancouver, and after reviewing the chart and one that will build more suitable for the hospital, he might say,
You know what? Thanks to these very useful, helpful guidelines, I'm thinking about my lab ordering more often, and my patient has been stable for the past couple of days, but she's on repeat orders of lab draws. I don't really need them. I have no plan of action for these results anyway, so I could probably take her off. Yeah, absolutely. We can take those off. We'll go to your chart right now.
That's great.
So, you can see a solution. You can see we've solved some of these problems. But there's one other we didn't touch on yet, and that is this. This pile of money. What is this pile of money, and how large is it? This pile of money is $906 billion. That is the estimated annual U.S. healthcare spending that goes to waste. That's a large number. And some of this comes from daily blood draws. So, what can we do? Well, the good news is this problem is not unique to Mount Sinai Hospital by a long shot. And there are documented success stories, particularly with daily blood draws, that have been done to show that we can save money. And they range from one study that showed a $55,000 saving after an 11-week intervention to annual savings between $151,000 and $400,000 each year in U.S. hospitals. So, we can follow these models, we can propose our solutions, and let's take a look at how this might work on Mount Sinai itself. This program is going to be implemented on 10 West in the coming months, weeks, whatever it may be. And so let's take a look at how this might work. The average cost of a CMP and CBC together is $30. Times that by the average number of CMP and CBCs ordered per patient day, which is 1.5, times the 36 patients on 10 West times 365 days a year gives you an average yearly spending on 10 West on blood draws of a whopping $591,300. So, if we can reduce the blood draws by just 10% on one floor of this hospital, we can save conservatively, and I repeat, this is a conservative estimate, nearly $60,000 per year. So, our medical administrators are happy, our department chairs are happy, we've saved some money. How about our patients? How about our doctors? Let's find out.
This is awesome. I am very satisfied with my healthcare at Mount Sinai.
And that'll lead to some good patient satisfaction surveys. And how about our doctors?
I'm definitely more conscious about my lab ordering, and my patients are just as healthy.
And so, they've been saved. Hopefully, this will bode well for the future of Mount Sinai, its hospitals, its doctors, its patients. Thank you very much for your time.
So I think just in terms of, all of these projects, by the way, were fantastic. I think what you guys are really doing is such a cultural change. I mean, it's really changing business as usual, which is fantastic. So are there ways that you can do this? Education is really key to changing culture. But then there's a carrot as well. Are there carrots that you guys can throw to, let's say, the intern? You know, I'm just curious, like, is there, I mean, there are certain motivators that you guys are using, I'm sorry, that sort of go into the patient's room, for instance, which I love. But are there other carrots that you can throw at the interns, at basically the end users?
So one thing we thought of is that currently there's a program where the floor or the group of hospitals with the most patients who are released by noon get a $50 gift card. So perhaps we could do something like this, tracking attendings and their teams to give some kind of gift card. That's one potential carrot.
Also keeping track of, well, you brought this up because you can keep track.
So I think a lot of the issues is that the interns may worry that they are needing to order these tests just so that if their attendings were to ask them why didn't you order BMP, they'd feel like they made a huge error and then they'd have to do a whole other blood draw. So what we were considering was tracking by the hospitalist on a per month basis, and then being able to show at end of the month report at what the spending is on according to each hospitalist, which will allow more of a top-down shift. Whereas now the attendings are more worried about it, and they'll be trying to enforce their interns to follow
Great, so
and really think about
that's
it.
sort of a negative reinforcement model, that's a positive reinforcement model. Both of these, by the way, are used in healthcare. And now, for instance, I reap some of the benefits as a provider, for instance, if I save money on my patient, for instance, right? I reap some of the benefits through Medicare. These are both potentially ways, and I love the idea of actually using both types of reinforcement. The problem with negative reinforcement, and this is sort of a practice that happens commonly, is that over time, physicians will ignore negative reinforcement because that's sort of a practice. So there's something about the carrot that's actually a pretty prime motivator. You may know that we know this from the medical literature. So it's something to think about. Is there something beyond what you're doing that would be helpful?
Yeah, so again, another great presentation. If the doctor thing doesn't work out, you can definitely sell a ShamWow or 17 CDs, it's a great future in that for sure. So, and I think starting with the education and the culture is definitely crucial to this, and I think it's a big piece of what you're going to do. But getting to systems level, I guess one question I have is, should we ever be able to order daily labs? In other words, is there a logic to a rationale to saying indefinite daily labs without a time limit maybe we should take it off of the as an option?
We were considering that for Epic, and that's one thing we came to, is that maybe there would be some kind of, I don't know how many day limit would be appropriate. We'd have to look at the literature and saying every, 3 days, 10 days, whatever it may be, you've got to manually renew it for appropriate indications as that list might show.
Yes, I would, as you explore this further, I would consider that.
I would also say for the positive feedback kind of thing, I think monthly is good, but if you can make it more than that, like weekly, like that's sort of like constant, just like, oh, I'm doing better, I'm doing worse, that's really great. I mean, I think that changes behavior. Whereas if it's a month or 2 months, people just forget, like they get busy doing other stuff. The other thing I would just say is I love that there's a patient part of this. I think that that's an important key that we often forget in quality, patient safety, all this stuff is we don't have the patient involved in whatever's happening. So I think that's great to sort of encourage people, whether they do it or not, it's sort of beside the point.
Dennis, I think that intern to patient interaction was probably the best interaction I've ever seen. As an intern, I mean, there are many interns that just ignore the patients. So, if you say, "Well, have you considered checking my hemoglobin today?" And I'm like, "What? Really?" So Dr. Google, patients Google everything, and they ask for inappropriate things sometimes. So that's actually I think that's a really overly optimistic interaction that you just So one thing that's been done, I know in the UK and in other countries, is that you can actually put the cost of the test next to the ordering. So like sHVC, $28 and so on. And you can actually subdivide it. So it may be that in someone with CKD, someone who comes in with glomerulonephritis, they may actually need a creatinine every 2-3 days. But maybe a creatinine is a lot cheaper than a BNP or a CNP. So that'd be another way of just sort of breaking it down. Yeah.
I mean, I think it would change.
A&A.
Yeah, absolutely. Well, I have to say, there are actually a lot of studies of that
Yeah.
that show that it sort of changes things initially, and then it just dampens over time because people start ignoring it.
Yeah. So you have to educate the
Are you cutting us? Are you about to cut us off?
Oh, no, I just did a lit review on this topic, so it's like,
there you go.
Yeah, Brigham and Women MGA had done a randomized control trial where they showed like costs and charges for these labs over like long period of time, and basically showed that there was actually not much difference in terms of their ordering habits. So there have been other studies, like prospective, other things that have shown kind of cost reduction, but actually big study that was done at MGH and Brigham, which was randomized, kind of did not show any difference.
And that makes sense, unless you're conscious, unless you're the one that's spending the money, right? So it makes sense, right? So for instance, at eHealth, right, we spend the money, not so much on labs, but on drugs. So if we can see the cost, it changes behavior. But if you're not the one spending the money, who cares? It's the insurance that pays for it.
I know Cleveland Clinic did this, and they actually, their revenue went down by over $1 million in a year by just decreasing costs, which is a good thing, but the institution lost money.
Right.
So there is that there is that
Right.
tension, and I think you guys are the future, and I think you're going down the right track.
Yeah, I wanted to make a completely different point. I agree. I think this is a great project. I'm actually doing the same thing at Sloan Kettering, so I would love to talk to you guys. I just did a huge survey trying to figure out the drivers. But one of the things that you didn't talk about is what you're going to track over time besides utilization. So you have to think about the things, people are going to be afraid that they're missing things by not doing labs, so there are some kind of like patient outcomes you really ought to track. And plus things like length of stay. You may shorten length of stay by doing fewer labs, but there's probably a whole host of things that you ought to track when this intervention starts.
Although maybe this is a good thing for like QI, getting QI, this is sort of an ongoing, so this is phase one. Then next year, maybe phase two. So, yeah.
okay. Well, great. Thank you so much, everyone. We're now going to the most exciting part, which is the judging. So we first have I just tried it. I think the judges portion is up and running. Please let me know if there are any issues. And then we also have the audience response. So just because we're running out of time, I think we're actually going to have to do it to 1 minute. Well, we'll do it start at 2. But it should be up and running. This is what you put in your browser. This is the number to log in. Take it away, guys.
Sure. You speak for it. Do it. Do it, John.
I'm going to make QI great again.
You can't vote for yourself?
Yeah, you can vote for yourself.
There's no shame and no one can know.
Literally, but often. Respond to that.
Oh, it's 1 o'clock.
Yeah. Is it working for everyone?
Yeah.
It's all slow, but.
That's easy.
Very
7, 5, 6. Done. Real QI.
Sorry.
That's what you do.
I used the first key. Should I do it again?
The faculty need help. Walk out.
This is just for kids, right?
Yeah.
Okay. still loading. Do you want to make the announcement?
Oh, no, no, you go ahead.
Okay. All right, so all of our 5 judges have voted. Thank you very much. All right, so let's see. In 3rd place, drum roll. In 3rd place comes our PPI group. Okay. Then in 2nd place, drum roll, is our group on daily labs. That worked out really well. Our winner is our folate group.
Yeah.
Okay, and now we will look at what our audience favorite was. Give me 1 second, guys. This may take a second. I don't think that worked. Yeah, hang on. Sorry, guys. It's not coming up on the screen here. Okay, so the audience favorite, however, with 19 out of, I don't know, 37 responses, was the daily labs. Final remarks, Harry?
I don't. Judges, anything fun?
I'll say, I think you guys all did a fantastic job preparing. You were all well prepared. You had great background and context, and you gave great presentations. This is really fun.
Yeah, this should go to the residents. I mean, the residents should hear this.
Yeah.
It's pretty amazing.
Yeah. What we'd like in the future is to kind of do this annually with sort of the same things with the student group, and maybe with next year we'll compare it with the residents, because I think there's a lot of interest there and a lot of working together.
You guys should do this in a new conference.
Yeah.
What did they win?
Right?
So we haven't found that out yet. Definitely get bragging rights. But thank you guys so much for working so hard. These guys are the meeting on a weekly basis trying to get all the data. Thank you guys. And, mentors, so Celine, Dr. Shinwa, and Dr. Found. Great job, guys.
You're a great cameraman.
Dude, the struggle, it's real.
I think John and Irene
have not heard the last of the TPI, guys.
No, man.
No, it's fine. I'm not.
Hey,
what's up?
Good job. That was great.
Before I get too much in the presentation.
Yeah, I'd like to chat. I think so too.
It's good. It's good.
Dr. Shinwa. Can we get a photo of you guys teams together?
Outside California.
We should get food. Everyone needs to get food.
Thank you so much, everyone. That was really
I'll definitely be in touch with you now.
Oh yeah, we need to get photos of the groups. I hope no one left. No, no, no.
Good.
No!
One
No! It's the one thing we needed to do. We need photos.
Oh, we can still do it.
Of the groups. Who left?
Where you're like, hey, there's $905 billion in like healthcare.
Yeah.
Some of that could be doing
It's like saying, everyone come in. Come on. Everyone come in.
the US. Some of those happen in Africa.